I want to say hello to all of our viewers and thank you for joining us. My name is Catherine Sullivan DiCarlo. I am Vice President of Admissions and Marketing at Chapel Haven Schleifer Center. And we really appreciate your time and your participation today. And this is part 2 of a 2-part series. Last week we had Dr. Abha Gupta talking about genetics and connections with autism, and she gave a really fascinating talk. And today we're happy to have Dr. Roger Joe, who is no stranger to us at Chapel Haven. He has done counseling and some work with many of our individuals and is truly an expert in autism. And so we're happy to have you join us. So our agenda will be that I'm going to give you a quick overview about Chapel Haven and give some introductions, and then we'll get into the talk with Dr. Joe. Along the way, if you have questions, you can use the chat. You can type your questions into the chat and we'll keep track of those, and Dr. Joe is comfortable answering those as we go along. And I should mention that we are recording the session. We do find that people who can't make it really enjoy the chance to see it at another time. So Chapel Haven Schleifer Center is based in the Westville section of New Haven. We were founded in 1972, so we're almost 50 years old now. And our goal is to help adults learn how to live independently. And so we provide a truly individualized program for profiles from Down syndrome and developmental disabilities to autism to a whole range of profiles, but all with the same goal in mind, which is learning to have your own independent life. And we offer residential programs, day programming, we have weekend recreation, we help people find meaningful employment. And we also have Chapel Haven Online, which is our virtual programming. So there's a lot of different ways that you can be involved with Chapel Haven. And we invite you to check us out. Our next open house, we've been having virtual open houses, and they're quite an easy way to get a good look at what we're all about and to meet student ambassadors and other parents and ask questions. So our next one will be on a Saturday morning in the new year. So Saturday, January 16th at 11 a.m. And if you'd like to register, you can just give me an email. And you can see my email right there on the screen. So now to our main topic today. And I really want to thank Dr. Joe. We've done a number of collaborations with him. And he's a psychiatrist and a researcher at the Yale Child Study Center, who has been focused on autism across the lifespan for the last 20 years. He founded the CASey program at Yale, Community Autism Socials, in 2014. And I know that some of our adults actually take part in that, providing free social recreation, education, and support for American autism communities. And that program is now known as CASey Sparks Autism Innovation and Discovery. And especially since the pandemic, Dr. Joe's research has been diverse, ranging from clinical trials to studying neuroanatomical diversity using MRI technology. He's also a principal investigator for SPARK at Yale, the largest genetic study of autism ever done. And so you'll hear a little bit about that today too, and you can contribute to the research and be involved in the SPARK study, and it's quite easy to do. So I'm going to turn this over now to Dr. Joe.
Great. Thank you so much, Catherine, for that kind intro. It's, again, a real pleasure to be talking with the Chapel Haven crew again. This is becoming to be like a regular thing for us, huh? That's great. You know, one of the things that I give this other talk about, sort of silver linings in the pandemic. And one thing that sort of comes up a lot is how people that we've known for a long time, we are working with them a lot more, than we sort of ever have been prior to the pandemic. Uh, and yeah, it's almost been like an unexpected, benefit, because uh, normally, we would do things, maybe once a year, now and then. But now that everything is virtual, we have these things sort of going on almost multiple times a month. So it's been really great to get to know people in this different context. So today I'm going to talk about mental health, medications, and the autism spectrum. I'm going to make this talk as intuitive as possible, and it's going to be a few parts to it. So there's going to be a part on mental health, and we're going to talk a little bit about medications, and then we're going to talk a little bit about intervention and how the field is changing with regard to development in science and technology. So let me just jump in here. First slide is always about disclosures. So we do get some funding for our program development through the Daniel Jordan Field Foundation, the Rosen family, and we are involved in multiple research studies, ranging from pharmaceuticals to SPARK, which stands for Simon's Foundation Powering Autism Research for Knowledge. And I think that's pretty relevant to this talk, and you'll sort of see how it is towards the end. So we don't have that much time, so we're going to make this really succinct. So I'm going to start from, let's rewind to the beginning. So when we talk about, mental health and, people's sort of well-being, psychological, emotional well-being, you could argue that it's traced back to even before you're born. So, there's some genetic predisposition. But for the sake of our illustration here, we're going to talk about, we're going to say the beginning of time is when you're born, and we all have a different life experience. And I think that's kind of obvious, but just because it's obvious doesn't mean it's really well understood. So a lot of people say this, but how much do they really understand it? So this next slide here is something called like a lifeline, and what it is very, it's a very visual way of maybe understanding how lives can differ over time, and how events in somebody's life can affect their well-being. So on the horizontal axis, you see years. On the vertical axis, you see levels of distress. So there's ranges from okay, good times, to stressful times. So in a typical person, this is maybe something that you would see. This is not population data, but this is just sort of consistent with maybe a lot of people's experience with their own lives and maybe other people that they know. So presumably everyone starts out feeling okay. And then you have these events in life: birth of a sibling, school, difficult teachers, changing in schools, so major transitions, major milestones, that are challenging and potentially very anxiety provoking, and sort of determines the trajectory of your future. So these are common things: exams, college, getting a job, marriage, stuff like that. And overall, you see that it goes up and down, and this is consistent, I think, with our experience. But overall, you'll see that maybe for the typical person, your everyday person, that you're feeling okay for the most part, even though there are times where you're going to be pretty stressed. So this is if we can say that this is an example of somebody who is neurotypical. So
thank you, Amma. I love you.
What happens when you have something different? When people are born with a different set of abilities, or some people would say disability, autism being potentially one of them. And this is based on the old diagnostic system of social impairments, communication, speech difficulties, repetitive behaviors. So if this is, you're coming into the world with autism, then how would this lifeline look? And you can see that you may guess that it's going to not look the same, as somebody who is neurotypical. And, this is one of the sayings I hear a lot in adults who are on the spectrum is that, you're born into the world that's not quite made for you. And, this is sort of a consequence, if you believe that is something that's true. And that a lot of things, you're going to go through some of the same things, but probably a lot of other things too. Um, so, overall, life, you're sort of living, a large portion not feeling so okay, because the world that you live in, is not congruent with, how you prefer to interact with the world or how you experience the world. So those experiences, that discrepancy is going to cause more distress. So if you can see this, if this makes sense to you, then it may be more intuitive that if you have a neurodevelopmental difference, you can see how that may put you at risk for certain other things. Most common things are anxiety, depression. So if the world doesn't fit with how you think about the world, that may create a level of nervousness, when if you tend to make mistakes, in these settings, and people aren't very forgiving, or people can be quite harsh, then that could increase anxiety, lead to depression. If there's ADHD or thought disorders, then those things could also come to the surface as well. So these are not completely based on your social or life experience. There may be some genetic predisposition. But, if you have this difference and your experience of the world, is rather challenging, then it may put you at greater risk for some of these mental health challenges. So the most common thing we do, is we want to understand, why people are going through what they're going through, So in terms of psychiatric practice, excuse me, we certainly do not advocate for meds up front, because meds have side effects, and a lot of times, you don't get a complete response, so we always want to make sure that we are exhausting, the less invasive, lifestyle options, before we start talking about meds. So, these are almost topics that certainly deserve their own presentation. But there's behavioral techniques, things like meditation, relaxation. So thinking about other ways that you can habits you can form, or routines you can have, or strategies, if you want to call them, tools in a toolbox. These are things that you can go to if you're feeling distressed. And of course, if you need to talk it out, then there's people who are expert at doing that. And maybe if you're not willing to talk it out, or if you can't talk it out, or maybe it doesn't work so well, then there's sort of behavioral approaches, and that is really in the realm of things like ABA, PRT. So those things may be an option. And if none of that stuff works, then we can start having this discussion about medicine. So assuming we've done all that other stuff, jump into meds. And this is a brief overview of the different kind of meds that we would prescribe. So anxiolytics are for anxiety. We've got antidepressants, obviously, for depression. And mood stabilizers, that are thought to help even out the mood, prevents these extreme highs and lows. Then ADHD meds for things like attention deficit, impulsivity, hyperactivity, then antipsychotics. So these are meds that are typically used for thought disorders. So there's a lot of details here, but I just definitely want to give you a sampling, of what we do, what meds we would use for what particular problems, and how common are these problems in the autism population. So moving first to anxiety disorders, I think there's a colleague that told me there's two kinds of people in this world. There's the anxious and then there's the dead. So we always have, I think everyone has experience with anxiety. So I think we all sort of relate to what that is. There's different diagnostic entities. So when anxiety reaches a certain threshold where it becomes impairing or disabling, then we start to think about anxiety becoming a disorder. And these are the different kinds of disorders that we would see. And how common is it in ASD? Well, these are just a sampling of some older studies. You can see that the range varies, but I think really what is common here and what's consistent is there's a high percentage of folks on the spectrum that are living with anxiety. And many would actually cross the threshold of it becoming a disorder. So what do we use to treat? What's a little ironic here is the medicine that we use that is specifically for anxiety is typically avoided for anxiety. So this class of medications called benzodiazepines are developed for anxiety. And the reason why they're avoided is because even though they could work very well, they also eventually stop working. And then what happens is, you need to increase the dose little by little to a point where that you're sort of at the maximum dose, but it doesn't really do what it's supposed to do anymore. So then you're stuck with the problem of becoming dependent on it. And when you're dependent on stuff like this, it's really tough to get off of, because if you're on it, you just can't stop it. Stopping stuff like this when you're taking it for a while can lead to a lot of withdrawal symptoms, with the most dangerous thing being seizures, which can be life-threatening. So, these are used for maybe some short-term situations, or when safer alternatives you've tried all of them and just don't work. The medicine we commonly use for anxiety are antidepressants. Most of them are in this SSRI category. So these are the selective serotonin reuptake inhibitors. The most common, here are some really common ones like Celexa, Lexapro, Prozac, Paxil, Zoloft. These are all good for treating different kinds of anxiety disorders, but they are technically in the antidepressant category. There are some older medications that are used prior to this generation of neurotransmitter reuptake inhibitors. We had something called cyclic antidepressants, and these worked, but they were quite deadly, especially in overdose situations. So these have a much safer margin. So these are definitely the preferred meds. Alrighty, so let's move to depression. And the great thing about the treatment of depression is it is very similar to the treatment of anxiety disorders. Again, ups and downs are normal. Everybody's mood sort of varies. We always try to explain this to people that moods can be something like weather in New England. It's can be pretty bad sometimes. Sometimes it feels like it's never going to go away. Other times, it feels like everything's good. So one day can be really bad, next day is totally fine. Moods are kind of like that. So some up and down in your mood is normal, and it's important to know that, so we don't stress ourselves out too much when we're feeling a way that we don't like to feel. Again, this is something that's very common, in ASD, also obviously in typical populations. But depression and anxiety tend to go hand in hand. So what's great about the treatment is that they're very similar. So with antidepressants, we also reach for the same medications. So the SSRIs are primarily the mainstay of treatment for anxiety disorders. There's other sort of variants of SSRI that target different neurotransmitter systems. Uh, they also are deemed pretty effective and very safe compared to these cyclic antidepressants, which I mentioned earlier are more lethal in overdose. If the depression is related to sort of a mood disorder, like a bipolar disorder, then you may reach for something like lithium or anticonvulsants, which are used to prevent the extreme highs and lows of people's mood. These are also used for the treatment of irritability and aggression too. So I think the point here to make is that irritability and aggression can have multiple sources. So it could be, a result of depression. It could be a result of anxiety. It can be, sort of a mixed mania or potentially a manic episode. But sometimes all we know is the behavior, and we try to make our best educated guess on how to approach that based on our understanding of what's driving it. All right, so ADHD and impulsivity, these are things I think we've also come to understand are pretty common, not just in ASD, but in the general population. These are the different subtypes. What's important here is that if you're primarily inattentive, then this subtype tends to get missed. If you have a lot of hyperactivity and impulsivity, these are the folks who tend to grab the attention of school teachers and families because it does tend to affect other people more than the inattentive subtypes. Again, very common in ASD, up to 50%. And the mainstay here is a few options. The psychostimulants are part of the main treatments, but these are not necessarily the medications we would first go to, for neurodiverse populations, because even though they could work very well, and the great thing about these meds is you find out pretty quick whether they're going to work or not, because their onset is fairly rapid, as opposed to some of those other meds I discussed. You can need to be on those medications like 4 to 8 weeks on the right dose and be compliant, and that's sort of a very gray area, before you can deem something as effective or not. These meds you'll know pretty quickly. And the reason why we wouldn't necessarily go to them first for neurodiverse populations is because they can have fairly pretty serious side effects. Probably the most fearful being things like increasing aggression, hostility, irritability. So you may try to reach for this because you're trying to help somebody with maybe they've got issues with impulsivity and aggression, and you give this medication to them, you can have an escalation of aggression. So that's why it becomes a little risky. Instead, we reach commonly for this class of medications here, alpha adrenergic agonists, which include clonidine and guanfacine. These are not stimulants. They're actually traditionally used to control blood pressure. And studies have shown that they also work for ADHD. So these medications, obviously, you would watch out for sedation and blood pressure. But they would tend not to have the side effect of aggression or irritability. So we would usually do something like this first. All right, so psychosis. Now this is something that certainly less common, but it can look a lot of different ways. So it could be, you can have positive symptoms, hallucinations, thought disorders, delusions, or grossly disorganized behavior or language, or you can have a lot of these negative symptoms, which are sort of amotivation, lack of drive, or scarceness of someone's speech, flattened affect. These are common diagnostic entities here, and in some studies up to 35%, certainly not common, but definitely more common than you would in a neurotypical population. And these conditions are treated with antipsychotics. There's different generations, which are they're named on when these medications were developed. So the first generation of antipsychotics, Haldol and chlorpromazine, are the most commonly known. That's Thorazine is the other name for chlorpromazine. And there's a second generation, which includes risperidone, which is one of the meds that has an FDA approval for use in irritability in autism. Then third generation is aripiprazole or Abilify, also has an FDA indication to treat irritability and aggression associated with autism. So these medications are very notorious for side effects. I mean, all meds have side effects, but the risperidones, for instance, and all these first generation certainly known for movement disorders. Second generation more for things like weight gain, metabolic side effects. So we really tried this as sort of last resort, in terms of treatment of irritability and aggression. All right, so let me see what time we have here, a few minutes. Okay, so this, for people who are have had experience with mental health meds, it's a very frustrating process, because they certainly work a lot differently than, say, if you went to your primary care doctor for an infection or you had high blood pressure or high blood sugar. Those meds, they seem to be predictable. We don't really expect a lot of side effects. But with these mental health meds, side effects are they're almost like the expectation, and if it works, then, you feel like, oh, you're lucky. So it's a very, very frustrating process. And I think a lot of folks, rightfully so, are very reluctant to go down that path. So over decades, science has been trying to figure out, okay, well, how can we take less of the guesswork out of this? And then this is where we come to the topic of pharmacogenomics. So this is using genetic knowledge, about how someone's genetic makeup in fact impacts how medications are processed and work in someone's body. So really it is, the intersection of genetics and pharmacology. And what we're looking at in terms of people's understanding people's gene expression is how the medications are absorbed, distributed in the body, how they're metabolized and eliminated, what drug receptors they hit and what the effects are. And in theory, if you know enough about the genetic makeup and people's response to medicines, then you can get information on what genetic types or what medications work for what genetic types. And this allows you to maximize effectiveness, try to avoid some of these side effects, no less of this trial and error approach, and really not a new concept. So this is something that's been used very common in oncology. It's probably the most commonly cited example, where they determine the genetics of, say, a tumor, and then they tailor the intervention based on what the genetics show. Now, this is being brought into mental health, and it's been in development for actually many years now. And this is one example of a test that you might get, which is a saliva sample or cheek swab of somebody's individual who you're considering for medications. And then this is sent out to a lab which analyzes the genetics, and then gives you a readout of what medications are recommended, what you might use with caution, and what you might try to avoid or use very, very cautiously. So one example, these certainly work very well for learning about metabolism, in terms of predicting what medication is actually going to work for who, that is something that is much harder to predict and much more complicated. But doesn't mean that it is impossible. In fact, I do think that the way that medicine is going in general, not just for people who are neurodiverse, but for just everyone, is figuring out how to use something as precise and detailed as your genetic makeup to then predict what intervention or treatment would work best for you. And this is where I think Spark fits in here, because really Spark, if folks who have not heard about Spark, just give you a brief overview. It is probably the largest autism genetic study ever, but it's not just about genetics. Genetics are part of it. A big part of Spark is actually being involved in a research community. So genetics, that's one of the first things you do, but part of it is really an ongoing project. I like to think of it as a partnership between scientists and people who are on the autism spectrum and their families, because what we're trying to do is we're trying to use data, lots and lots of data, to predict what works for who based on genetics, and a lot of medicine is going in this direction, and one thing we know about research is if you don't participate in research, then it may not benefit you as much. So there's a history behind this, and that a lot of research back in the old days were based on using men as participants. But could you extrapolate those results to women? That was tried, it didn't work out so well. So now it's pretty common sense now that men and women need to be represented in research studies. You can extend that over to different minority populations, or neurodiverse populations. If you do not participate, then the likelihood those results will apply to you become more slim, which is why we really are encouraging people to become involved in the study. This is more of a pictorial representation of what I just said. But basically, we want to use data. We want our interventions to be data driven. And genetics is the next step into personalizing or making the interventions more precise to the individual. So just a couple of myths that we're trying to debunk here. So no, Spark does not look for a cure for autism. Not everyone gets a genetic result because this is something that is a process of discovery. So every time new results or new genetic predictors come in, that's when we would contact folks who've had those genetic results in the past if there's a match. Also, there's no intent to develop genetic testing for autism as well. So those are sort of the common myths that we encounter for this study. But I think the more we know, the better that we can do for everybody. And this is just a general principle in medicine, not just talking about neurodiverse populations. We're talking about everybody. So if we, in the words of, I believe, Maya Angelou, if we know better, then we can do better. So happy to take any questions. And thank you for tuning in and listening.
I was curious about I saw the slide about motor tics, and is that symptomatic of anxiety, or is it driven by neurological factors or genetic factors in the autism? Can you just flesh that out?
I think it's both. So usually we think of those conditions as people having a genetic predisposition. Genetics on a lot of these behavioral health diagnoses or phenomena are very complicated. So there's multiple genes involved. There's different levels of likelihood of whether somebody can happen. One way to think about it is that when people start to exhibit the symptoms, it is a combination of different thresholds. So they meet a genetic threshold, but they're also meeting this environmental threshold, which can include external stress and anxiety. So if you have folks who are at high genetic risk for developing a condition, and the environment is so that you're also raising sort of that environmental threshold, then you can get the manifestation of the condition. So if that's tics, then you can have people who have tics now and then, or maybe, certain times of the year they have them, or maybe certain situations they have them, or people who have them most of the time, and then they worsen on, when more stress or there's changes in the environment. So that's kind of the I'm trying to make it as simple as possible. Does that make sense?
Yeah. So basically, when trying to, from a special education standpoint, and I'm working with students who have had support. I have students in their 30s and their 20s. I guess I was just trying to see how to help them develop certain strategies, and whether that's, using more anxiety based, or if there were other like techniques. And so I was just trying to, I know that's a bigger question for another time, but that was the impetus for my question there. So I guess what it is it's very dependent on the situation and the condition, but it's really, we would have to look at both aspects.
Right. And you can't change the biological part, but you
Right.
can tweak or adjust the environmental stuff,
Mhm.
or how somebody reacts to having tics, or how maybe other people react to them. So those are things that you can control. And I think it's great that that's how you're approaching it.
Excellent. And then Joseph has a great question about melatonin. Joseph, did you want to ask your question? Okay, well.
Yes, sorry,
Oh.
coming on.
That's okay.
Just wanted to ask if I tuned in a little bit after the start. So did you talk about melatonin for autism, anxiety / depression?
I haven't talked on sleep disorders or sleep difficulties or melatonin, but I'm glad you brought that up, because it is a very common problem. Melatonin, I think it's one of those, sort of is on the edge of being a medicine versus, some kind of a food supplement, and you see it pretty much like everywhere. Whether or not it works particularly well for people with autism, I've heard there's sort of mixed reviews on that. So I think really the only way to know is to try it, but got to make sure that you're taking the right amount. You got to make sure that you're also practicing good sleep hygiene, because I find that one of the common reasons why people have sleep difficulties is related to their practices around sleep hygiene. So what they're doing around the time they're trying to go to sleep. So melatonin used in a more holistic approach, making sure that you're practicing good sleep hygiene, I think tends to be in my experience, tends to be pretty successful. And the good thing about melatonin is it's not one of those meds that have these really funny side effects. So some sleep meds, whether it be like trazodone or Remeron or Sinequan, these are all prescription meds that are antidepressants, but they're sedating, so they're commonly used in treatment of sleep. Those meds can cause weight gain. They can make people groggy in the morning. They require prescription. And then there's sleep meds like Ambien and Lunesta and Sonata. These are have other side effects. Probably the most one of the most feared side effects is the sleepwalking and inability to sort of remember what happened when you were supposedly awake at night. And those are typically only used short term. Melatonin, there's not a, generally I haven't heard of anyone becoming, dependent on melatonin in a physiologic way. Haven't heard of anyone withdrawing from melatonin. These are meds that are used in children as well. So it's a pretty low risk medicine, and something that I mean, I commonly would recommend sort of a first time or first line um, intervention, if everyone, if their sleep hygiene is good too, and they just need a little something extra, to get a better night's sleep.
Okay, I think I might be muted. Marissa, am I muted?
No, I can hear you.
Okay. I was wondering one final question. Do you find that there's a drug or a go-to med that doctors prescribe, sort of knee-jerk reaction for autism, that you think is a mistake? I know it's a weird question.
Yeah, I mean, I think that there's a lot of, when I was talking about that slide on antipsychotics, um, which include, even those FDA-approved interventions for treatment of irritability associated with autism. There's a lot of use of those meds, which are, certainly if there's safety concerns and, things need to be as quick as possible, but under control, that may influence how quickly you would prescribe something like that. But I think it's a mistake to think that, these are meds that are that have sort of minimal consequence, short-term and long-term. So I think the mistake really is when the meds are reflexive, sort of, as you're saying, Catherine, it's more like a reflex. Somebody has aggression or somebody is, very irritable, that these are just automatically prescribed, which is, why in the beginning we're talking about other ways, to deal with behavioral challenges than going to medications, because all meds have side effects. I think that really should be the expectation, not the exception. And so when you're reaching for medication, that's something that you are, in a sense, consenting to the risk of that. And which is why we don't, at least I do not, typically just jump to medicine, because it can either work really well, or it could have the opposite, or some in between. But there are, it's unnecessary risk if you can address it in some other ways. And certainly, there are tons of examples where it just doesn't make sense to wait, or those things have been addressed. In those cases, you can make a decision based on a conversation with the person and their family. But I think the important thing is really knowing that these things come with significant risk, and before something is prescribed or taken, that those risks, benefits, alternatives should be reviewed, so everyone's on the same page of what they're getting into.
Well, I really want to thank you. This was very, very interesting. I don't know, Christy, how you feel, but I'm glad we're recording this because, a lot of times we'll get intake information on a prospective candidate and we'll look at the meds they're on, but I can't say that at least I don't know as much about these meds as you just laid out for us. So it's quite interesting. And there's so much to learn.
Yeah, and it keeps on changing. It's an evolving science.
Right.
I think the future is, we really like to take less of the guesswork out of it. And we can do that through, some of these research studies. So, if we can catch up to our guys in primary care and medicine and, have more targeted interventions, that have less side effects and more effectiveness, then, that is the ultimate goal.
Well, I want to thank you, and I hope that we can partner up in 2021 because I'd like to do some more of these. I think there's a real need and people are very interested. So thank you again, Dr. Joe.
Thank you for having me.
Okay, thanks everybody.
Thank you. Bye-bye.
Bye, Andrew.